Hello, everyone who is tuning in, and welcome back for the next installment in my ongoing series regarding my favorite functional medicine screening tests. Up till now, the testing has all been very decidedly do-at-home testing. This panel of tests, the advanced cholesterol test, as I'm calling it, is a blood test, and it's a blood test done by doing venipuncture, essentially putting a needle into a vein to draw out a couple of milliliters of blood to be able to run all of the various tests that need to be performed. Um, and as such, it needs to be done by a trained phlebotomist or a nurse. That is able to be done at home. There are services that will send a mobile phlebotomist wherever the need for blood draw happens to be. And it is also possible to go to an area lab and have this blood work drawn at the lab. So I've kind of opened up the parameters a little bit. This testing certainly can be done at home. Most often, though, I would say it's probably done at a professional lab setting. So with that being said, let's just move right along. Financial disclosure as per usual. And then also just wanted to provide the latest update with respect to COVID-19. Found it very interesting that even though the number of confirmed cases, again, that's an issue we talked about a couple of weeks ago, has gone up, and pretty noticeably, certainly, the number of confirmed fatalities from these cases has started to level off and even decline a bit. So that's a little bit of good news there on the COVID-19 front. Also of note, there was a study that was just published last week that I saw that I found very interesting in light of the previous webinar that I offered on supplementation to best prevent COVID-19. This was a European study that looked at accumulated data from 20 different European countries, and it found a negative correlation between vitamin D levels and COVID-19 cases and mortality due to those cases. As the study authors wrote, we found significant crude, admittedly, relationships between vitamin D levels and the number of COVID-19 cases, and especially the mortality caused by this infection. They went on to say the most vulnerable group of population for COVID-19, the aging population, is also the one that has the most deficit vitamin D levels. Now, this study was done in Europe, so they use a slightly different metric for how they quantify vitamin D levels. Theirs is in terms of nanomoles per liter, whereas here in the States, we typically use nanograms per milliliter. So a little bit of math, and you can transfer back and forth between these two ways of stipulating levels. The average vitamin D level found in their study was 56.79 nanomoles per liter, which equates to 22.75 nanograms per milliliter. They included a couple of graphs, and you can see this essentially negative correlation that applies to both the actual number of cases there on the right and the mortality from these cases there on the left. That down and to the right slope of the mean that is calculated statistically shows that negative correlation. The higher the vitamin D level, the less likely actually coming down with COVID-19 or dying because of it. And just to refresh from that very first webinar that I gave, gosh, 6 weeks ago or so now, vitamin D is important for all of these reasons. The RDA, as stated by oversight bodies here in the US, 600 international units a day. I've been recommending on average 5,000 international units daily for my patients. A larger amount may be needed if you happen to be an older individual. Really though, the best way to determine it is based on a blood test. So check what your serum level is and then dose accordingly. I like to see my patients' blood levels around 70 nanograms per milliliter. So that's almost 3 times the average level that was seen as the result of that study. Now, moving on to the advanced cholesterol testing. This is Dr. Mark Houston. This is the very, very smart doctor from whom I learned most of this approach to treating cardiovascular disease from a functional perspective. He was my primary teacher during my fellowship. He's also written this great book if you are interested in a deeper dive on the subject. And a lot of what I'm about to present draws from what he has written in this book. Definitely worth a look if you want to know more. Just briefly, as we do always, let's do a little bit of anatomy. I think most people are pretty familiar, broadly speaking, with the cardiovascular system. Heart, of course, is a mechanical pump. Diving deeper than that, there's a whole lot more going on from an energetic perspective. But broadly speaking, yes, the heart is mechanically pumping blood. It leaves the heart after it's been oxygenated in the lungs by way of the aorta, that first outflow track from the left side of the heart, to be distributed to the rest of the body, to carry oxygen, to carry nutrients, and ultimately to pick up metabolic wastes and bring them back again to the center via the venous network. And then those wastes can be disposed of as needed. The carbon dioxide can be breathed out, and anything else can be filtered out in the kidneys or in the spleen, or so on and so forth. Now, I also want to draw your attention to this first outflow from the aorta, these coronary arteries. The heart, understandably, has to take care of itself. So this is really the first offshoot from the aorta, is the heart supplying itself with blood so that it will have enough oxygen and nutrients to keep undertaking those mechanical muscular actions of pumping. And really, this is where we start to have issues when we have cardiovascular disease, coronary artery disease specifically, and where the problem has developed when people talk about heart attacks. Looking a little bit more specifically at the blood vessels themselves, and we're largely going to focus our attentions today on the arterial side of things. But I really appreciated this schematic because it just sort of lays out all of the anatomic pieces of these various components of the vascular system. On the arterial side, I want to draw your attention to this region that's called the tunica media. This is basically a middle component of the artery that is comprised largely of smooth muscle. That is to say, muscle that's not really in our conscious control. The brain, via its autonomic nervous connections, is regulating how tightly these muscle cells are contracting. Somewhat differently than, say, skeletal muscle, like your biceps or your quads and so forth. This musculature in this middle layer is very important because it's going to help to control the flow of blood throughout the body at a regional level. The tighter these muscles contract, the narrower the lumen, or the opening of the artery, will be, and therefore the less blood throughput there will be. The more they relax, the reverse of that, it'll be more open, more blood can come through. And this makes sense. If you need to run away from the tiger, you want more blood to be directed to your muscles so that you can get away. If you've just had Thanksgiving, then you want more blood to go to your digestive system so that you can manage that heavy load. This will also have a bearing on blood pressure. This mechanism of action, this regulation, this constriction at the tunica media level, the more that is going on, the tighter the lumen is, and therefore the higher the pressure inside the artery becomes, and the higher the blood pressure as a result of that. I also want to draw your attention to the endothelium, which is the innermost layer of the artery. Now, again, we have this on the venous side as well, but again, we're really going to be just largely focusing on the arterial side today. This is a 1-cell layer thick interior lining of the artery that's going to be very, very important to this conversation, as you'll see as we dig further into it. The endothelium itself, as Dr. Houston says, is the largest organ in the body. If we want to think about it as an organ, if we were to somehow be able to remove all of it from an individual and lay it all out flat as a sheet, it would be 6.5 tennis courts in size, that amount of area. Again, it's one cell layer thick, and this is somewhat reminiscent of the intestinal epithelium that we talked about 2 weeks ago during this webinar series. And it's also similar to a structure in the body called the blood-brain barrier, another very important one cell layer thick interface within the body, just like the intestinal epithelium, that we're not going to really get into today, but suffice it to say that as a functional medicine practitioner, these specific structures within the body, one cell layer thick, are vitally important for a whole host of different reasons. Now, the endothelium itself is in direct contact with the blood flowing through the arteries, which I think most people can reasonably understand. And as a result, that means it's also in contact with all the hormones that are traveling through the bloodstream. If there happen to be bacteria present, then it's going to be in touch with them. And it's also going to be the recipient of the physical stresses that are placed upon it by blood rushing through the arterial system. For the most part, our bodies are able to handle that well, but we'll see that there can be some ways in which that can become a little problematic. Some have referred to the endothelium as the arterial brain. It's really not just an inert lining just sitting there on the inside of the artery right next to the blood. It's actually doing a lot to manage the homeostatic needs of the vascular system. Most importantly, it is situated optimally just between the blood and that vascular smooth muscle layer that we spoke about a moment ago. And in terms of cardiovascular disease, the endothelium really does need to maintain its structural and its functional integrity in order to prevent cardiovascular disease progression. As an osteopath, I really love that concept of structure and function being interrelated at every level. This is just another example of that here within the cardiovascular system. The endothelium itself is responsible for any number of features that fall under that broad category of homeostasis, as I just mentioned. It does act as a barrier. It really controls access from within the bloodstream to those deeper structures on the interior of the artery. And we're going to see a little bit more about that here in a minute. It is important in fighting disease, and it helps to regulate how the immune system behaves within the artery. It controls inflammation and oxidative stress, maintains homeostasis, as we've been saying, and it helps to regulate blood pressure by the production and release of nitric oxide, which is it's basically a chemical messenger that causes smooth muscles within the arteries to relax and thereby open up and let more blood through and decrease the overall pressure of that blood flowing through the artery. Moreover, it is important in fine-tuning how thick the blood is as it's moving through the arteries, and it is very important in terms of how the blood clots or doesn't clot. When we think about and talk about cardiovascular disease, the idea of endothelial dysfunction is an important idea to add into the mix. This type of problem results from any sort of physical or chemical damage that is visited upon the endothelium. There is a potential for basically any of those responsibilities on the previous slide to become disordered with the development of endothelial dysfunction. That barrier responsibility can start to break down, and LDL, low density lipoprotein, the so-called bad cholesterol, can start to penetrate through and take up residence deep to that endothelial lining. White blood cells, proteins as well, can cross over in that fashion. There can be increased arterial stiffening and constriction of arteries, which increases the blood pressure because of a reduction in the amount of nitric oxide that's produced and released. Overall, this looks like an increase in levels of inflammation and oxidative stress. And importantly, this can also result in blood that is thicker and more likely to clot. This whole idea actually becomes a bit of a vicious cycle, so that as endothelial dysfunction develops and starts to set in, it becomes more likely that further endothelial dysfunction will result because of this dropping of the ball, so to speak, with these various endothelial responsibilities. Now, there are over 400 different biochemical and biomechanical causes of endothelial dysfunction. In response to that huge variety of different insults, there's really only 3 potential responses that the endothelium can take. It can respond with inflammation, it can respond with oxidative stress, and it can respond by overactivation of the immune system, which is a bit of an autoimmunity that starts to set in. Each of these responses ultimately leads to the development and the progression of cardiovascular disease, leading to more endothelial dysfunction and vascular smooth muscle thickening, which leads to increased blood pressure and raises all kinds of additional risks for mortality in that individual. Now, these are the top 25 modifiable cardiovascular disease risk factors. This is, again, from Dr. Houston's book. As I said earlier, there's over 400, but these are sort of the main ones that we think about. Some of these you may be familiar with, others might be somewhat new to you. The idea, though, is that inflammation and oxidative stress are really the response, and they lead to the propagation, that vicious cycle effect with respect to cardiovascular disease and endothelial dysfunction. Now, if we go see any doctor, any general practitioner, primary care doctor, for the first time, we have a complete physical. We're going to sit down with that physician and we're going to talk, and there might be some conversation related to these various factors. In all likelihood, your vitals will be checked, so there will be some sense about blood pressure. The doctor may ask you about whether you smoke. They may ask you about your diet, things like that, how stressed you are. And based on that consultation, there might be some labs that are ordered, which would take a look at several other factors in this list of the top 25 risk factors. So that's all well and good, but there's still a lot of different potential factors that are being missed out on, including the 2 big ones, inflammation and oxidative stress. With the use of this advanced cholesterol testing approach, we gain insight to a bunch of different factors, as well as deeper insight into dyslipidemia and hyperglycemia. Now, we specifically get a reading for the HSCRP. We also get a specific reading for homocystinemia, and that gives us some sense of what's going on from an inflammatory perspective. When working with a functional medicine physician, such as myself, we do also have access to other types of specialty testing that literally can evaluate each and every single one of these different factors. Definitely talking up my own book here, but I wouldn't be a functional medicine practitioner if I didn't believe in the value of this approach. And simply stated, it is looking for root causes and, whenever possible, seeking to address those root causes before they blossom into full-blown pathology. If we have this information, we can act on it. And the sooner we have this information, the sooner we can act on it and thereby reduce those consequences of inaction. Now, the old perspective of cardiovascular disease, and this goes back decades, 50, 60 years, I don't know, something like that, longer than I've been alive, was essentially that too much fat, too much cholesterol in your diet over time led to a steady buildup of plaque inside the arteries, thereby ultimately blocking off blood flow specifically within those coronary arteries that would result in a heart attack. And that was really a very overly simplistic perspective on what was happening. As we'll see, it's actually quite a bit more complex than that. The current understanding revolves around this concept of endothelial injury. And you can think of that almost as a microscopic scratch of sorts within the interior of the artery, just like if you got a paper cut on your finger. Just a tiny little injury. And if you've ever had a paper cut, you've seen probably how it's become a little bit red, it's become a little bit painful. That's inflammation, which in and of itself is not a bad thing. It's inflammation that has gone on too long, has gotten too out of control. That's when the problems start to develop. By and large, these types of different endothelial injuries, as we've seen the whole list of, are not things that are just sort of one-offs like a paper cut is. They tend to be factors of lifestyle, of diet, of not getting enough exercise, being a smoker, things that we aren't just doing one time and that's it. They tend to persist. And as a result, there is this development of that vicious cycle type response because the body, in its inherent wisdom, is trying to respond to that injury. But because that inflammatory response persists, what we get ultimately is a deposition of white blood cells, platelets, smooth muscle cells, and then most importantly, these last two, the oxidized, smaller, denser types of LDL and various clotting substances deep to that endothelial layer of the artery. Ultimately, though, the body does do what it can to heal that injury, and oftentimes there is what's known as a fibrous cap that develops over the site of the injury within the artery. Now, this is exposed to the lumen of the artery, so that all the blood rushing by and all the shear and stress and physical forces of that. But you can literally think of this as an arterial scab of sorts. This imagery here gives you a sense of what that looks like. On the left, sort of the normal human artery, the endothelium clearly marked there, that one cell layer thick interior lining. And then on the right, the development of an atherosclerotic plaque. There's a bulging out into the lumen of the artery because of the deposition of all of these various substances. But by and large, this is walled off from the blood flow that is just passing by in an ongoing fashion through the artery. Now, the lumen can become quite blocked over this process of atherosclerotic plaque development. If the plaque is stable, as we would call it, that plaque can continue to grow and may get up to an 80% in terms of its blockage of the arterial flow without the development of any symptoms. There are even recorded cases of arteries being blocked up to 98% with only really pretty mild symptoms. That would be things like chest pain, fatigue, weakness, that sort of thing. The worst outcomes from this sort of pathologic development, however, come about when that plaque is what we would call unstable. And that is when that fibrous cap overlying the plaque is more likely to be essentially ripped off. If you've ever had a scab that's gotten ripped off because you put your pants on too quickly or you weren't paying attention, all of a sudden you can see blood starting to kind of rush out depending on how big it was. This can happen inside the arteries. And then what happens, instead of blood coming out, it's all of those contents deep to that endothelial lining are now free to come rushing out into the artery. And those various clotting factors that are present to a greater or lesser degree, when they come into contact with blood, can cause the development of an instantaneous clot. And when that happens here in one of the coronary arteries, that's when we get a sudden heart attack develop. And depending on where that happens in that whole arterial tree, that would be relatively mild to quite devastating. You can see that whole schematic as it's shown here. the plaque with the cap rupturing, and then the development of that clot, which completely occludes flow within that artery. So all of this conversation, to my mind, begs the question, what is cholesterol? You know, we have all, I think, probably heard about cholesterol. Cholesterol is bad. It's certainly been portrayed as such for the past 40 or 50 years or more. But the reality is that cholesterol is a natural substance that is manufactured by the body and is essentially a building block, a raw material for all kinds of very important things throughout the body. We need it for healthy cell membranes. That is throughout the body. That's really important. We need it for bile acids. They help us to be able to digest the fats that we take in dietarily. We need it as a precursor to the development of vitamin D, and that's sort of in that classic sense of, let me go out in the sun, let me get some healthy, reasonable sunlight exposure. We need enough cholesterol in order for our body to be able to produce vitamin D in response to that appropriate sunlight exposure. It's also the building block for steroid hormones and reproductive hormones. Cholesterol itself is essentially a type of fat. As I've been saying, it's absolutely necessary for life. And even mildly or moderately elevated levels of cholesterol are not necessarily bad. This is part of the reason why I ideologically don't want to practice in a way that just reflexively leaps to cholesterol lowering medications in response to conventional cholesterol testing. Now, we'll get into that a little bit more here in the future, but mildly or moderately elevated levels are not necessarily bad. In some cases, that can be the way that the body is seeking to protect itself against various toxins or chronic infections. And it's really only becomes bad if there are certain other conditions present, and we'll talk about that. Now, historically, it's sort of been lumped into, most people are familiar with two different types, but really historically there have been three different types. LDL, low density lipoprotein, the so-called bad cholesterol. This is what tends to deposit in arteries. Now, it's not quite as simple as that, but that's largely the story. It's called low density lipoprotein because it has less protein overall and more cholesterol and fat, and as a result, it's less dense. So that makes sense. It's a great name for it. There's also very low density lipoprotein. This has even less protein and even more cholesterol fat, so it's really low density relative to the low density type. The high density lipoprotein, the HDL, or the so-called good cholesterol, has been called good because it does really great things for us. It carries away cholesterol and fat that has been deposited in the artery. So it sort of helps to recycle it, keep it from getting in the way, causing these atherosclerotic plaque developments or worsenings of those plaques. And it's called high density because it has more protein, less cholesterol and fat, and as a result, it's denser. You can think of it as that fat is sort of being shuttled back and forth between the low density or the very low density and the high density. The high density just has a greater capacity to absorb it, pick it up, take it back to the liver to be reprocessed. Now, this theory was developed decades ago, and it essentially assumed that within those three different categories, all of the particles were essentially identical. So if we're talking about LDL, there's only one type. If you're talking about VLDL, only one type, and same for HDL. We have since learned that that is not exactly true. But let's take a look for a minute at a standard lipid profile. If you go to your primary care doctor and they say, I want to check your cholesterol, this is what you're going to get. You're going to get a test panel back with 4 assessed values. You're going to get a total cholesterol level. You're going to get the LDL, the so-called bad cholesterol. You're going to get the HDL, the so-called good cholesterol. And you're also going to get something called triglycerides, which is a factor we haven't really talked about. Triglycerides are another type of fat. That's why this whole test panel is called a lipid panel. Triglycerides are another type of fat that are basically a storage form of energy. Oftentimes, this is, if we've eaten too much food that we don't really need to make use of in a metabolic, energetic sense right in that moment, the liver will convert carbohydrates, what have you, into triglycerides so that they can be circulated throughout the body to ultimately arrive at a place of storage, an adipose cell. When we are being really active and we haven't had enough to eat, the body will say, oof, we need more energy. It will call upon those energetic stores. Fat is essentially the most dense way to store energy. And this makes a ton of sense. This is also why your doctor will say, I want you to go to the lab in a fasting state, nothing to eat for at least 8 hours before you get the blood drawn, so that we won't be looking at your triglycerides based on the last meal you ate 2 hours earlier. This will just be, what are the levels of triglycerides that are circulating as a baseline? Now, in addition to those values, we get some calculated values as well. We get the cholesterol to HDL value, and this is one way of using total cholesterol to HDL as a way to stratify risk. It's a little bit rough. It's not as refined as what we get from the advanced cholesterol testing, but it does have value. We also get the non-HDL cholesterol, which is essentially a window into what the VLDL, the very low density lipoprotein, might look like based on inference. This value is essentially subtracting the HDL from the total cholesterol. So you're essentially getting the LDL and the VLDL from that calculation. In terms of advanced cholesterol testing, there are multiple different providers. Usually I work with SpectraCell. That's just the test that I've ordered the most. There are some, logistical issues with that. I'm also willing to work with other labs, but for the sake of this webinar, you are going to see results from a SpectraCell report. Now, pricing is, of course, important when there is a medical necessity, and that can be as simple as I had high cholesterol on a conventional lipid panel that my primary care ordered for me. That is enough in order to say, insurance, we'd like you to help us pay for this more specialized testing. At the low end, it can look like $50 or so, but there's usually some sort of laboratory fee in terms of where the blood is actually drawn that is assessed as well. So at the low end, that bumps it up to about $75 if insurance is somewhat restrictive, or if we don't have the medical justification for ordering. If you as an individual just say, you know what, I'd really like to take a look at this, we can certainly do that. You would just pay out of pocket, and we'd be looking at something more like $150 with the blood draw fees included. Now, on this SpectraCell advanced cholesterol testing panel, we do get the conventional lipid panel as well. So total cholesterol, triglycerides, the so-called good, the so-called bad, and then the non-good cholesterol, which is basically the LDL and the VLDL together. We get really great color coding. It's a nice layout. We can see how things are looking, and that's useful information. Again, not as much as we will get from everything else. To broaden the perspective a little bit, the current understanding with respect to low density lipoprotein, the so-called bad cholesterol, is that there are really 3 different types, not just one type. Each type behaves somewhat differently. To speak about them generally, there's lipoprotein A. We sometimes call this LP little a. This is basically just a regular old LDL, but it has an additional protein attached to it. As a result of that additional protein, it is far more active in the development of clots and therefore blocked arteries than just regular LDL. Now, this is largely determined by genetics. When I see a value of this past a certain threshold, it's a pretty safe bet that there is a genetic predisposition towards the development of higher amounts of LP little a. It's usually fine, normal, or it's really, really high. It's one or the other. Now, there's also intermediate density lipoprotein, and this is essentially that very low density lipoprotein that's on its way to becoming just regular low density lipoprotein. And this happens as it deposits some of that fat and cholesterol that it's carrying around. And as it lightens up on those less dense constituents of itself, it's essentially graduating up in density towards LDL. And intermediate density lipoprotein is also important. We need to be aware of levels of that if we want to take this more holistic perspective. Everything else is essentially lumped into the category of LDL real, and within that, LDL can be just as itself, or it can become oxidized. And when it becomes oxidized, that is when it is far more prone to developing those types of subendothelial plaques. Now, with respect to HDL, the so-called good cholesterol, there's at least 5 distinct forms that we know of. Overall, similar to the inheritability of the Lp(a), that initial subtype on the LDL slide just previous, sizes of HDL are largely inherited. The idea here is that the bigger the particle size of the HDL, the more protective, the more beneficial it is for that individual's cardiovascular health. HDL2 is one of the larger, less dense varieties of the good cholesterol. It is really the most protective, especially the subtype HDL2B. So don't worry about all the detail, just know that it's more nuanced than the conventional approach has treated it for the past 50 years or so. There's also HDL3. This is a little bit smaller, it's a little bit more dense, but it's also very protective. So these two types are the most important types of HDL. Now, even though the sizes are largely an inheritable trait, there are different things that can be done to help increase specifically HDL2B. To wit, exercise, lose weight if you're overweight, quit smoking, restrict refined carbohydrates, don't eat trans fats, keep a lid on the amount of saturated fats, not to say that you shouldn't eat any, but not out of reason. And you can also increase your intake of niacin, which is B3, pantethine, which is B5, and omega-3s. Now, these just happen to be the things that cardiologists have been telling us to do for decades in order to promote cardiovascular health. This is why they promote cardiovascular health. They are specifically helping to increase levels of HDL2B. If we want to compare the conventional lipid panel to this advanced cholesterol panel, the conventional assessment is looking at the total mass of cholesterol. So it's given in terms of milligrams of cholesterol per deciliter of blood looked at. And we get that in terms of LDL-C or HDL-C, which just means low density lipoprotein cholesterol, HDL lipoprotein cholesterol. It's sort of a generic, all-encompassing assessment. The advanced assessment is looking as well at the concentration of individual particles. And this is given in terms of nanomoles per liter. So moles is a chemistry term which deals with the actual number of particles of a molecule, whatever it is, whether it's cholesterol or whether it's H2O, and in terms of an overall volume. So nanomoles per liter, and this is designated as LDLP, LDL particle, or HDLP particle. On the SpectraCell Advanced Cholesterol Testing panel, we get this whole section of lipoprotein particle numbers. And these numbers each sort of have their own recommended regions that are more ideal and to be avoided regions that are less ideal and more problematic. And then there's also sort of this middling ground in between. Some of these are sort of, the scale is flipped. So if you look towards the bottom in terms of the HDL particles, and specifically those HDL2B, those most protective beneficial particles, the scale goes essentially at the low end on the right to the high end on the left. That way we keep all of the ideal values, all of those green bars towards the left of the scale. So just to help orient you around that. And based on various scientific investigations, different levels of these different particles have been assessed to be more beneficial or more concerning, just as similar sort of values have been established for the conventional approach. So another way to sort of characterize this data, also available on the SpectraCell test, is via this graph. And a lot of my patients actually really appreciate this approach better because you can really see this trend. The idea here, and I'm not going to get too deep into it, we don't really have enough time to, is that these particles are essentially decreasing in size as we move from the left to the right. So those very low density lipoprotein particles are the biggest particles if we were to be able to see them in real life, whereas the HDL, the so-called good particles, are the smallest of the particles. Now, the idea here, broadly speaking, is that the larger the particle, whether it's HDL, LDL, or VLDL, the better and the more protective, the more encouraging of cardiovascular risk it is for the individual. And this is for very different reasons. On the HDL side, the so-called good, the bigger the particle, the more accumulated fat and LDL cholesterol it can pick up as it is traveling around in the bloodstream. The bigger the particle in terms of the LDL, the harder it is for that particle to essentially penetrate deep to that endothelial lining and thereby cause issues down the line in terms of atherosclerotic plaque development. And similarly, in terms of the VLDL. This speaks to the idea of why advanced cholesterol testing is so helpful. We can do a conventional cholesterol test and we can see, oh, your numbers look great. Let's check again in a year or two. But we don't really know which particle type of LDL is present. We don't know which particle type of HDL is present. If those numbers are comprised largely of the smaller of these two different types of cholesterol, the LDL and the HDL, even though the overall mass looks good, the particle size characterization is very concerning. And we wouldn't realize that from simply undertaking a conventional lipid panel. By the same token, if we run conventional cholesterol testing and our numbers are off, your doctor may say, you know what, you need to start a statin. And we're going to check this again in a couple of weeks or a couple of months, and then thereafter. And oh, by the way, that might cause problems for your liver. And please let me know if you start experiencing muscle pain, because that is one of the most common, well-known side effects of these statin medications. Not to mention the impact on your overall supplies of cholesterol that is so important for hormone production, vitamin D production, cell membrane integrity, on and on. And that step could have been taken without truly needing to, because all of those cholesterol numbers are actually stemming from the larger particle size. Legitimately, if those are all smaller particles, both bad and good, then yeah, a statin may be the right choice. But I'd rather know the actual particle size characterization before undertaking that treatment intervention. Now, we do get some additional markers of inflammation on this advanced cholesterol panel. HSCRP, that was one of the top 25 modifiable values. This is high sensitivity C-reactive protein. It's a protein that's produced by the liver. Any inflammatory process can cause an elevation in it, but in the absence of an obvious cause, cardiovascular inflammation is likely the culprit. And it really has been shown to be, through all kinds of studies, the most predictive of all cardiovascular indicators. We also get lipoprotein A, which is that specific subtype of LDL. It has that additional protein attached. It raises the risk of clots and blocked arteries significantly. And again, it's largely determined by genetics. There are certain actions that we can take if we find that to be elevated, but I would not really be recommending those to just anybody. I would really want to know that there is an objective, identifiable concern before undertaking those actions. We also get an assessment of homocysteine, which is an amino acid. It's manufactured by the body. It's not typically used structurally the way other amino acids are. It's really more of a messenger. And it's broken down relatively quickly within the bloodstream by different enzymes that need folic acid and B6 as cofactors. Having too much homocysteine reduces the levels of nitric oxide that the endothelium can produce, and thereby help to regulate the overall diameter of arteries, and thereby the blood pressure and all of the other issues that can come from that. So you can see we get that in addition to insulin. We also get apolipoprotein B and A1. We don't need to go into those right now. But this is a very comprehensive panel of tests that really gives us a much fuller sense of the cardiovascular health and risk characterization for that individual looking into the future. Now, this is essentially my best all-purpose cardiovascular set of recommendations. This largely comes from Dr. Houston, who has been practicing for decades more than I have. He is a cardiologist. He has so much more experience with this than I do, and I lean heavily on his recommendations, but I recommend this comprehensive cohort of suggestions to patients all the time. Now, some of these, specifically within the supplementation region, would likely need to be tailored a bit depending on the results of an advanced cholesterol test panel. But by and large, these recommendations are appropriate for any adult who is otherwise doing well. To the extent that there was family history or concern based on symptoms or signs that might be picked up in a physical exam, and or results from an advanced cardiovascular test, these recommendations might change. They might become a little bit more exhaustive, a little bit more inclusive of other options, but these recommendations would be appropriate, as I said, for any adult who is otherwise healthy and looking to be as healthy as possible from a cardiovascular perspective. Now, we're just about out of time, so just to recap in terms of my practice, I'm definitely doing a lot more telemedicine lately, have been making complimentary 15-minute supplement consultations available to anyone, whether a patient or not. Anyone wishing to become a patient can certainly avail themselves of that complimentary consult, can also undertake a telemed initial half of that first visit, 30 minutes remotely, and existing patients can also avail themselves of telemedicine consults. The complimentary consults also come with access to a 10% lifetime discount via FullScript, which carries only pharmaceutical grade supplements. And that basically allows me to make specific recommendations that can be tailored to your areas of interest and need. Anyone who is an existing patient also already has access to the 15% discount. Now, pharmaceutical grade supplements are important because they provide a standardized dose that has been subjected to rigorous quality control without the addition of any extraneous fillers. And then using FullScript in particular allows for control over how that particular bottle of whatever supplement has been stored, how quickly it's been turned over so that it hasn't expired, under what conditions it's been shipped, and if anything does go wrong, access to great customer service. Now, after all of COVID-19 blows over, I'll be doing new and existing functional medicine consultations, new and existing osteopathic treatment appointments. I just started back on a case-by-case basis last week with osteopathic treatments here in my office. So if that is of interest to you, please reach out and we can discuss that possibility. I will also continue to provide telemedicine options for existing patients as needed and as that makes sense. And then the complimentary consultations regarding supplements and access to FullScript will also be ongoing. Next week, I intend to discuss intracellular micronutrient testing, which is also a blood test that can be done at home, but is usually done in a lab. This is really another one of the main functional medicine screening labs. And if there's an interest in doing advanced cholesterol testing, the intracellular micronutrient testing can be rolled into the same blood draw. It's very easily accomplished. So with that being said, I really wish to thank you very kindly for indulging me for an extra 5 minutes. It doesn't look like there are any questions at this point. So with that, I am going to say thank you, thank you, thank you. Reach out if there's anything that I can do to support your process, and wish you well and encourage you to stay very safe and very healthy out there. Thank you. Bye-bye.